Okie dokie, so we are getting started here. The next cardio section, we'll do 2 cardio sections for this next grouping. We'll do kind of the meds that, if you don't take your hypertension meds like you're supposed to or control your diabetes, these are all meds that you have to take for this kind of stuff. And then we'll do antiarrhythmics in the next section, so that will be recorded and posted online, hopefully by the end of Friday, depending on the weather. So anywho, so we'll get started with this stuff. First thing we'll talk about is angina, however you like to say it. I hear a lot of people still call it angina, like in the medical profession. So I'll say angina. So certainly this is going to be kind of a symptom of ischemic heart disease. We know this is going to be an issue of an imbalance between either the amount of oxygen getting to the heart or the amount of oxygen that the heart needs in order to help oxygenate appropriately. And then you have this term of coronary heart disease. This is where you're going to have these atherosclerotic narrowing of some of the coronary arteries, right? So you can have acute coronary syndrome where, we'll talk about unstable angina, acute MI, kind of falls in that category. We'll have the sudden cardiac death that can occur, chronic stable angina. We'll talk about all those as manifestations of this coronary heart disease. And then you have angina, which will be basically just those clinical manifestations of that oxygen imbalance, so that chest pain that the patients are going to be experiencing. So again, we're going to be looking at the medications that will kind of either work on 2 fronts. So one will either decrease the amount of oxygen the heart needs, or it's going to end up supplying more oxygen to the heart. So basically kind of either focusing on one of those 2 kind of mechanisms. So similar to how we saw in glaucoma, either increase the amount of aqueous humor flowing out or you decrease the production. We're kind of doing a similar tactic here. So it's important to know which medications are going to be good for working on which mechanisms. And then the other big thing we're going to focus on for these different medications is based on their other disease states, which drugs are going to be most appropriate for them, right? We'll talk about also things that have mortality benefits and things that don't. So that's another important thing to remember. Some things are just for symptomatic relief. Not everything is going to necessarily increase or decrease mortality for your patients in the long run. So looking at the heart rate, a couple things that go into that include the contractility, right? And then we're also going to be looking at the wall tension that's being that is exerted on the heart itself. So a lot of this is affected by not only ventricular volume, but also the pressure that the heart's going to be pumping against. So this is really an effect of either both the preload and the afterload. So the preload is going to be the initial stretching. So this is going to be kind of the volume returning back to the heart, or that diastolic volume. And then you'll have your afterload as well, and that'll be the pressure that your heart is pumping against, is where a lot of our antihypertensives are going to be working to help decrease some of that afterload, right? And then your vessels, as we age and we have more atherosclerotic plaque start to develop, eventually when they completely fill up the entire vessel, cause some occlusion. That's where you can see, that unstable angina, that MI develop. But in the meantime, you can have this, kind of gentle progression where you have narrowing of the arteries. And it actually takes quite a bit before you'll see the symptoms of angina actually develop. So once you have the angina, you've probably got either a decent amount of arteries being occluded, or they have, one big one's got, pretty extensive occlusion happening there. So it can occur with any kind of degree of stenosis that's happening here. We're talking about kind of another variant of angina that can occur without really a large degree of stenosis. But certainly if your left main artery, if that's 50% or more, you can end up seeing symptoms of angina in roughly 75% of other major coronary vessels. This is actually really kind of hitting close to home for me, because I actually had my wife's or my mother-in-law's husband actually just had, he was driving down from wherever he's driving from. He's like he's a picker, I guess. He does like a lot of garage sales and stuff like that, and flips things. I don't know, the guy's weird. Anywho, he was driving down and started experiencing chest pain, and so ended up going, didn't want to do anything about it, because a lot of older guys, they don't necessarily want to do anything about the pain they're experiencing. Eventually, wife tells him to go to the hospital, goes in, ends up finding one vessel is 100% occluded. Fortunately, I actually didn't have an MI, no troponins or any other things like that, but ended up having PCI done, ended up having a stent placed. So it's kind of timely that we're talking about some of this stuff and some of the medication we're going to be using for that. So it can happen to anyone for sure. And so, like I said, he had 100% occlusion. So of course, that chest pain might have been was probably pretty significant for him. There's also this vasospastic or variant angina, this Prinzmetal angina, as you might hear it being referred to. So this is more to do with vessel spasming than it is necessarily doing with an actual occlusion of the vessel. The patients might have some degree of stenosis or an occlusion that can worsen it, but you may see this happening in relatively young patients that have fewer risk factors, and this is really more of an issue of autonomic function. And so, it can be so severe, you can have ST elevations, you can see, pretty significant ischemia occurring, but for the most part, you won't necessarily see that unless it's, very, very severe. And so we'll see certainly certain medications that will be more appropriate for this, and you'll see with other ones. So it'd be important to know, which drugs you use specifically for this versus just regular angina. Oftentimes you'll end up seeing during night or in the early morning hours, where it's most likely be presenting. So looking at the risk factors for angina, obviously there are some things that we can't modify, some things that we can, very similar to what we saw with nosocomial pneumonias. The non-modifiable ones are going to be basically our genetics and kind of, do we have family history of premature cardiovascular events? Your age will be influencing this. Obviously, males tend to have this at a younger age and females will typically be presenting with it. And then all your modifiable risk factors, so sedentary lifestyle, your diabetes, overweight, hypertension, all this kind of stuff, which hopefully you've been counseling your patients on and they're taking their medications for, but if they don't over a long period of time, they're not being treated for a while, this is where this starts to come in. So the treatment goals, the things we're going to be focusing on with our pharmacotherapy here is to increase the quantity of life. So obviously we want to be preventing acute coronary syndromes from developing in the first place. And then we want to increase the quality of life. So if we can help to relieve the symptoms of angina and help prevent them from occurring in the first place. And again, typically anginal symptoms happen when the patient is doing what? Yeah, when they're exerting themselves. So the idea would be if we can increase the amount that they can exert themselves before they develop symptoms, that's going to be another goal, right? Because that's increasing their quality of life because they can do more things before they really start to be kind of hindered by their angina. So we'll see that the treatment strategy is to, one, decrease the myocardial O2 demand. So we can do things like decrease heart rate, we can decrease contractility, and we can decrease intramyocardial wall tension. So that is both a factor of preload and afterload. So if we can decrease that, that's going to help with our O2 demand. We can increase the myocardial oxygen supply. So if we can maybe open up those coronary vessels some to increase blood flow, that can be helpful. And then we also want to look at other things which may not directly affect the angina, but if we can stabilize those plaques and prevent an acute coronary syndrome, that's going to be good for our patients long term. And then also if we can modify some of those other reversible risk factors. And you see a lot of these medications are going to be playing with other disease states as well. So if you have a CHF patient, you're going to see certain medications will be both good for angina and good for that. You'll see other medications that are good if they had previous MI or if they have diabetes. We'll focus on those, and it's important to remember those kind of those disease states and which medications are going to be affecting them, because that's going to influence what your main choice of medication is going to be. If I have a guy with diabetes who's had a previous heart attack, his choice of medications might be different than someone who has really no previous risk factors, right? So we'll take a look at that. Obviously, the one thing you could do is just to decrease the amount of occlusion in the vessel in the first place. So you could do your percutaneous coronary interventions or your PCIs, open up the vessel, place a stent, whatever you need to do. You could have a grafting done, so you could have a cabbage done. Has anyone ever seen like an open heart cabbage being done before? It's super cool. I've never seen something so cool in my life. They stopped this dude's heart, did the whole perfusion thing, chopped out all these vessels in his leg, put it back on the heart, and just starts up again. But that, that's super cool. But if you can do PCI, obviously much less invasive. Whether you do the balloon or place a stent, whatever it happens to be. As far as the pharmacotherapy, the things we'll be focusing on mainly, we'll be looking at our antianginals, which will include our beta blockers and calcium channel blockers, and also your nitrates. So those would be the main drugs you're going to be used to actually treat the symptoms of angina. And then you'll have your vascular protective drugs. And these are going to be things that don't actually have anything to do with the symptoms of angina, but help to prevent further progression of disease and hopefully to prevent that acute coronary syndrome. So anti-platelet agents, statins, and also our ACE inhibitors are going to fall into this category. And then obviously lifestyle changes, we can do any of those modifiable risk factors, have them quit smoking, whatever, those are going to be useful as well. So looking at the different mechanisms or the different treatment strategies, we can see that the things that are going to decrease heart rate, contractility, and systolic wall tension are going to be our calcium channel blockers. And if you had to think about which calcium channel blockers those would be, which ones would you think? Yeah, especially with the heart rate and the contractility, you're thinking non-dihydropyridines. But we will see a place for the dihydropyridines because they're going to be working preferentially on what? Yeah, on the vasculature. So you can end up seeing some of the coronary vasodilation that can occur. It can help to increase blood flow. So we'll talk about that. And then, like we said, increasing blood flow, we're going to see our calcium channel blockers, our nitrates, aspirin and clopidogrel also. Aspirin and clopidogrel are other ADP receptor antagonists. Can you guys think of any other ones in that category?
Clonidine?
Not clonidine. Like prasugrel, ticagrelor, those ADP receptor antagonists. So I put clopidogrel here just because it's the one that comes to mind most easily for me. But remember, there are other agents in that group that you should be able to recall for testing purposes. Anyway, those are going to be working specifically just to prevent further occlusion from happening, so they won't necessarily be working on the actual anginal symptoms, but they do help to increase the blood flow because they prevent the actual clot from occurring or further occlusion. So the idea by giving antianginals, we want to improve their exercise capacity, so let them do more activities before they start to become symptomatic, reduce any kind of like exercise-induced ST segment changes, and then also decrease the actual frequency of symptoms. So beta blockers, calcium channel blockers, and nitrates are our main categories here. Nitrates probably being the newest drugs that we'll talk about, but we'll recap some of the stuff with the other two that we already know. So again, we know that there's various classes of angina. Certainly has a lot to do with the symptom onset and how much basic physical activity they can do before they start to develop symptoms. Obviously, if they're having symptoms at rest, we would call that what? Yeah, it's unstable angina at that point, so then you're much more concerned about it. But certainly before that point, it's going to be based on basically how much activity they can do. So if we can maybe get them from, say, a class 3 down to a class 2 or class 1, that's going to be much better for our patients in terms of quality of life. So the first group we'll talk about are going to be our beta blockers. We're going to see that they primarily work on decreasing demand or decreasing oxygen demand on the heart. They don't really do a whole lot for the actual supply. Right, so they're not necessarily doing anything on the direct coronary vessels to increase blood flow, but they are decreasing the amount of oxygen the heart requires. So they're going to work obviously by decreasing heart rate, right? Because they're working on which receptors? Yeah, beta 1 specifically, right? Because those are the ones that are primarily responsible for increasing heart rate and contractility. They're going to decrease contractility through the same mechanism. They're also going to work to some degree to decrease some of that decrease some of the the preload by decreasing systolic blood pressure, and actually can relax the heart to some degree because you're slowing it down. You kind of give it more fill time, so you can actually increase the left ventricular volume to some degree, right? So all this is going to kind of help to reduce the amount of oxygen that the heart's going to need in order to help keep the body perfused. So typically you'll see that beta blockers are going to be your first line drugs for this unless they have any kind of contraindications. We'll talk about specific ones, but they are very useful for patients who have limited exercise capacity due to their angina. If they have coexisting hypertension, anxiety, especially if they, because beta blockers can be used for things like performance anxiety and things like that because they block a lot of those sympathetic nervous system kind of that fight or flight response to some degree. They're good for patients who have a history of supraventricular arrhythmias, heart failure. We'll talk about specific ones we're going to use for heart failure towards the end of this lecture. And then at their post-MI, we'll also see that they really need to be on a beta blocker. So that's why a lot of these patients, if you have a previous MI, you're probably going to have angina as well because you already had that pre-existing ischemia. So most of the time, this is why the beta blocker is going to be your first line drug. So you can use non-selective drugs, you can use beta-1 selective, it really doesn't matter for the most part. We'll talk about the situations where it will matter which agent you select. And these aren't the specific ones you have to use, these are just kind of examples, right? So our beta-1 selective ones, atenolol, metoprolol, some very common ones, some non-selective ones like nadolol, propranolol, and then those third generation agents like carvedilol and labetalol that have kind of some ancillary activity that will help to decrease blood pressure and things like that. So contraindications, so certainly if your patient already has kind of a pre-existing AV block, if they have a heart rate less than 60, that's kind of a relative contraindication to starting up a beta blocker. Certainly if they already have kind of a decreased systolic blood pressure less than 100, you typically don't want to start this one just because it's going to worsen that. And then if they're actually having an acute decompensated heart failure, this is going to be contraindicated. And why do you think that is?
Because you don't want to stop the heart from pumping.
Right, like they're having an acute decompensated heart failure. Their ejection fraction is probably not great. Their cardiac output's kind of poor. You don't want to give a drug that's going to worsen that. So that would be a contraindication if they're having an acute decompensated heart failure. And in general, you might want to be really, really careful with using beta blockers in heart failure. Obviously, precautions. If they had reactive airway disease, what kind of agents would we focus on using? Yeah, beta-1 selective, so like your atenolols, metoprolol would be a big one there. Again, systolic heart failure, again, you have the chance to worsen this. So you want to, again, anytime you're starting up a beta blocker in a patient with heart failure, you want to start low and go slow. That's really kind of the big mantra there. Why about diabetes? Why would that be a precaution? Right, so one, it can mask the symptoms of hypoglycemia, which is a bad thing. And what's the other thing it can do, potentially? Yeah.
Wasn't it hyper or hyper depending on?
It causes more hyperglycemia than anything, right? Because you end up decreasing insulin secretion and things like that. So typically you see your beta-1 selectives are a little bit better for that. So if you had a diabetic patient, you might focus maybe on more cardioselective, but certainly you can still see some negative effects on their blood glucose. And then peripheral vascular disease, again, this can worsen intermittent claudication and things like that. So beta blockers might not be so great for those. Obviously, our adverse reactions include things like hypotension, bradycardia. We talked about the hyperglycemia. Certainly, sexual dysfunction you can see with a lot of antihypertensives, and beta blockers fall in that category as well. Which ones do you think you'd see more nightmares with?
Fat-soluble ones, the propranolol.
Yeah, fat-soluble agents, more lipid-soluble ones like propranolol. It's kind of the poster child for that one. And again, patients that have peripheral vascular disease, that worsen claudication could be a side effect there. Obviously, monitoring for blood sugar. Look at their lipids, look at their heart rate. And why do we want to tell them to avoid rapid discontinuation? Absolutely. So you already know you have a patient who's predisposed to having ischemia. If I'm constantly blocking those receptors, they're going to do what? Upregulate or downregulate? They're going to upregulate because I'm blocking those receptors. And so if I were to take that away all of a sudden, now all of a sudden my sympathetic nervous system can really hammer on those receptors, increase O2 demand, and worsen the anginal symptoms. Maybe even put them into an acute coronary syndrome, right? So it could be that bad. And then again, dizziness, fatigue. Oftentimes for your older patients who may be more sensitive to this, start the doses at nighttime until they can get kind of used to it. That way they can kind of sleep through any of these issues they're having, especially like orthostatic hypotension and whatnot. Moving on, we'll then have our calcium channel blockers, and obviously you know that, oh yes?
Sorry, I just have a question.
Sure.
As you know, in the previous lectures when we talked about beta blockers, it can also cause exercise intolerance. So how do you find the balance between those two?
That's a great question. So you said beta blockers, we know they cause exercise intolerance, right? And then these are patients who already have exercise intolerance. So you kind of find that balance where, chances are their angina was kind of the rate limiting factor there previous, right? So by decreasing O2 demand, you'll probably actually get an increase in their exercise tolerance to some degree, because the issue for them isn't necessarily because normally, like, if you have a relatively young, healthy patient, right, and they went to go work out or go running or something like that, like the heart is not able to keep up and deliver enough oxygen to the rest of the body, and that's where you see the exercise intolerance, right? For these patients, you're really more worried about the blood flow to the heart, the oxygen demand on the heart. So normally they're going to hit the rate limiting factor over their angina before they really hit the exercise intolerance to the beta blocker. Right, so typically you're going to see a net positive. These are typically patients who are not out there running marathons in the first place, so you don't necessarily worry about that kind of exercise intolerance. This is more strictly due to the O2 demand by the heart. That's a very good question. Now, could you see a patient who has an issue with that as well? Absolutely. You may need to either titrate your dose or particularly maybe use a different agent depending on how sensitive they are to it. Moving on, then we have our calcium channel blocker. So we certainly know the differences in their activity between our dihydropyridines and then our non-dihydropyridines. So which ones are non-dihydro? Right, and then all of our dihydropyridines. Yeah, the penes, so like amlodipine, nifedipine, things like that. So these are going to be good to decrease oxygen demand by the heart. Which ones do you think are going to have a better effect on decreasing demand? Yeah, probably the non-DHPs, right? Because they're going to have more direct effects on the cardiac tissue. Looking at the non-dihydropyridines, we're going to see that they, are directly affecting the SA and the AV nodes. So they're decreasing heart rate, decreasing contractility. They're going to help to decrease systolic blood pressure, and they can help to decrease some of that left ventricular volume, but usually it's going to have kind of a net neutral effect on that. But the big things are the blood pressure, the contractility, and the heart rate. So those are good for the demand. We see with the dihydropyridines, if anything, they can potentially cause that reflex tachycardia. So they may not be the best option if you're going to use these as just a single agent. We'll talk about that in just a little bit. Not really going to have a ton of effects on contractility, but their big place where they're going to be working here are to decrease systolic blood pressure. So your non-dihydropyridines may be a potential first line for your patients, depending on comorbid conditions and whatnot. Typically, you'll see your dihydropyridines are going to be more add-on therapy, right? And then, as far as supply goes, you're going to see that the both of them will have activity here, but typically your dihydropyridines will have a little bit more activity here because they're going to cause some mild dilation, especially in those areas of fixed stenosis, and they can help to relieve some of our vasospasm. So we'll see where these are the drugs we're going to be using for that Prinz metal angina due to that vasospastic nature of it. So again, just kind of breaking it down into the different categories, you can see kind of more directly on what kind of effects they're going to have. We've kind of seen a chart similar to this before, so this is kind of old hat for you guys. Okay, so where we're going to use our calcium channel blocker. So they can be used for initial therapy of reduction of symptoms. If you have a patient who can either not tolerate a beta blocker, or maybe they did have some exercise intolerance due to that, or if they have some other contraindication, your non-dihydropyridines could be a first-line option for your patient. You can potentially use them as combination therapy. Say they're on a beta blocker and they're still having some symptoms. I mean, they've improved, but not really to the point where you're really comfortable with it. You can add on something like a dihydropyridine to those patients. So, why wouldn't you want to do a non-dihydropyridine in conjunction with a beta blocker? Yeah, way too many cardiodepressants on there. You're worried about worsening heart block, bradycardia. You don't want to do that. So DHPs could be an add-on to a beta blocker, but you don't want to do a non-dihydropyridine. And then you can also use them in combination with long-acting nitrates, which we'll talk about a little bit later. You can see that the main patients are going to be those that are not going to really be tolerant to beta blockers. Vasospastic angina, particularly the dihydropyridines, are going to be better for that, mainly because that's really just due strictly to an issue of coronary blood flow rather than it is O2 demand on the heart. So we'll see that dihydropyridines are going to be better for that. They have severe peripheral vascular disease. They're not going to worsen this to the same degree that like a beta blocker would. Asthmatic patients, uncontrolled diabetes, left ventricular dysfunction. If they have left ventricular dysfunction, you don't want to give a cardiodepressant necessarily, so your DHPs might be better for that type of patient. So again, another big thing to focus on here is you don't want to use short-acting agents. Typically, you want to have good long-term control of this, because if I had a short-acting agent, something like nifedipine, what do I worry about happening? Right, you worry about rebound effect that can occur with the drug basically kind of wearing off too shortly. So, you give it to your patient in the morning, they feel great, they're walking around, all of a sudden the drug wears off, and now they're starting to develop symptoms again. Using a longer acting agent like amlodipine can have a more sustained effect, so you don't have to worry about that kind of rebound happening there. Now, certainly you could use like a long-acting nifedipine type compound. So again, just focus on not using just immediate, really short-acting agents, but in particular. Contraindications, again, hypotension. If they have a heart rate less than 60, particularly for the non-dihydropyridines, it would be a relative contraindication. If they're having acute heart failure, again, similar to what we saw with the beta blockers, your non-dihydropyridines can worsen that, can maybe put them into an acute decompensation because of the cardiodepressant effects of that. And then again, you don't want to use these concurrently with beta blockers, specifically the non-DHPs. And then we also worry about CYP3A4 interactions. And which ones do we worry about causing those in particular? Yeah, your your non-dihydropyridine, so your verapamil, diltiazem, those are the main ones with the CYP interactions there. Okay. Then looking at some adverse reactions, so certainly hypotension is a potential whenever you're giving these. With the dihydropyridines, you're also, because of the vasodilatory effects, you worry about things like headache, flushing, peripheral edema that can happen here. And mainly for monitoring, you're really just going to be looking at the relief of symptoms, looking at if they can keep like a symptom diary. That's usually pretty useful, so you can monitor for changes over time. And then heart rate when you're using the non-dihydropyridines. And then obviously constipation is going to be a big side effect, so again, warn your patients about that. And orthostatic hypotension, dizziness, fatigue can all occur here as well. Then moving on, we have a new group of drugs we haven't talked about too much, but these are going to be our nitrates. You can end up seeing that the nitrates are very vasodilatory in nature. They're not specifically going to do a ton on necessarily the oxygen demand by the heart, because if anything, they can actually cause a reflex tachycardia, very similar to what we saw with the dihydropyridines. But one thing they can do is actually decrease your blood pressure and decrease left ventricular volume, so you do have some decrease in wall tension. They are also going to be working on the supply, so they're going to be dilating our coronary arteries, which is kind of one of the big things we're going to be seeing as far as efficacy goes, relieve some of that vasospasm, and then they can also have some antithrombotic and antiplatelet effects as well. So how do these drugs work? So we know that nitrates are going to be generating nitric oxide, and nitric oxide is going to have a positive effect on generating cyclic GMP. Cyclic GMP is going to be found within the blood vessels. It's going to help to increase protein kinase G, which actually decreases intracellular calcium. By decreasing intracellular calcium, which calcium is really important for muscle contraction, you actually decrease that. You're going to have more smooth muscle relaxation, and less vasodilation and decreased blood pressure. Right? So nitroglycerin, drugs like that are going to have very good effects to decrease blood pressure because of that effect of nitric oxide influencing that vasodilation there. Notice that one of the big enzymes that's responsible for metabolizing cyclic GMP is going to be phosphodiesterase 5 in particular. Phosphodiesterase 5 is inhibited by a group of drugs, sildenafil, tadalafil, and vardenafil. Do you know where else you see these being used? Yeah, erectile dysfunction, right? So we'll see a very, very important drug interaction here. So just remember this slide and remember that you have an interaction here. Anytime you're inhibiting phosphodiesterase 5, what's that going to do to your cyclic GMP concentrations? Should increase it, right? Because the enzyme responsible for metabolizing cGMP is going to be inhibited. So you're going to have more cGMP, and what's that going to do to your blood pressure? More cGMP, more vasodilation, more decreased blood pressure, right? So that's a very important drug interaction we'll talk about in just a little bit. Okay, so for acute relief of symptoms, so your patient has an acute exacerbation of this, acute chest pain, we're going to be using our short-acting nitrates. So really the big thing here is to help relieve acute symptoms of this myocardial ischemia, so deal directly with the pain, and hopefully to help prevent some effort-induced angina happening here. So a couple of different options. You can have things like sublingual sprays, so if you've ever taken a nitro spray. You also have the nitrostat. These are to be the sublingual tablet. So again, it's an important education point for them not to swallow it, but just keep it underneath their tongue. It'll dissolve and be absorbed effectively right there. Now again, these are short-acting agents, so typically they're going to be dosing it every 5 minutes while they're still having pain. And kind of the big rule for them as far as education goes is that if you still have symptoms 5 minutes after your first dose, call EMS. It used to be you take a few doses, and if you're still having symptoms, call EMS, but we know that time is tissue in these cases, and if they're having an actual coronary event, so after 5 minutes they're still having chest pain, go ahead and call EMS. Yes?
So is this what it's sublingual, but is this the exact one that they give, like when they bring patients to the ER?
Mm-hmm.
It's this one?
Yeah, exactly. Yeah, so like nitrostat, sublingual spray, depending on whatever they're carrying on, like the EMS rigs. This is kind of a good adjunct until you can get them on to like an IV nitrate, right? So if they're coming into the EMS or coming into the ER, they're still having pretty significant chest pain. You can give them switch them over to, especially if they're having a really bad hypertension, switch them over to IV nitrate there, nitroglycerin to help kind of manage that. But in the meantime, they're using these short-acting agents.
Okay.
Yep. Yes.
Typically,
yeah. So typically, a lot of those patients will send home with a prescription for that, especially if they have previous history of angina. I'm not sure if every patient's had an MI who's not experienced angina before would necessarily get it. I'd have to ask a cardiologist, but I would imagine, they probably would go home with a prescription for it, just because it's one of those things that when you're having that chest pain, like you want to do something about it, pretty immediately. So, yeah.
So you instruct them to call EMS if the first dose doesn't help.
Right. After 5 minutes, they're still having chest pain. Go ahead and call EMS. Right. And then we'll talk about other drugs you're going to use at the same time when they have that. So this is just kind of introducing the topic. So again, sitting or standing may enhance the effects of the nitrate. So again, orthostatic hypotension may be a big side effect here. You want to make sure you're storing the drugs in the original packaging, because nitroglycerin itself is pretty volatile, as you might imagine with like trinitroglycerin, right? TNT, explosive. Anywho, the stuff likes to decay pretty quickly, so you want to keep it in the original packaging. Notice the one before is in a tiny glass amber vial that keeps light and things like that from degrading the product. And make sure they're gonna, after it's open, replace after 3 or 6 months, right? So follow the packaging on that stuff, because otherwise, if it degrades to a point, they're having chest pain, all of a sudden they're taking their nitro and it's not working anymore. Well, is it because they're actually having continued ischemia, or is it because the drug is so degraded that it's not really working anymore? So it's important to make sure they're replacing that appropriately, even if, make sure to throw in the old stuff out. And I know a lot of old people that don't like to throw stuff out. They're being wasteful. Tell them it's not good anymore, right? And then, again, tell them not to swallow the product. Either, take the pill and put it underneath the tongue, or do the spray directly under the tongue. We do have long-acting nitrates that are going to be better for kind of long-term control and prevention of symptoms in the first place. So you won't see these being used as first-line therapy necessarily. Typically, you'll see them as adjuncts added onto other agents for the most part. So if they, for some reason, couldn't tolerate beta blockers and calcium channel blockers and really wasn't going to be working for them, either due to intolerance or due to just lack of efficacy, you could potentially try adding on one of these. Although at that point, you probably should be kind of investigating how bad their angina really is, and potentially getting some angiography or something done. But more often than not, they're going to be added in combination with the beta blocker or calcium channel blocker. So anyway, we'll get to the specific agents. So the ones we see here are going to be our isosorbide mononitrate, which is going to be a little bit longer acting agent. So this one's going to be lasting around 12 hours and we're getting dosed daily. And we also have our isosorbide dinitrate, which is going to be a shorter acting agent, maybe around 3 or 6 hours. This one gets dosed more frequently throughout the day to help control those symptoms and prevent acute angina from occurring. We also have nitro paste, or nitrobid. This is an ointment that you can actually place directly onto the skin to have transdermal absorption of nitroglycerin. They'll help to control symptoms from occurring. Big patient education points and also healthcare provider education points. One, it'll be dosed in inches, similar to what you saw like our ophthalmic ointments and things. So you'll have like this little kind of wax paper that comes with the product, and you'll basically dose it based on whatever your order is. So whether it's half an inch or say 2 inches per dose, you can see there's around 15 milligrams per inch there. You basically go ahead and smear it onto that to the appropriate length, and then you apply it directly onto the skin, usually the chest. And keep it covered with that paper. So obviously, if it's going to be transdermally absorbed by your patient, who else could it be absorbed by? Anyone who touches it, right? So it's not completely uncommon to have, say a nurse who's applying nitro paste and all of a sudden they're complaining of headache, right? And it's probably because they didn't use gloves or the appropriate type of gloves and actually had some absorption of it, right? So again, you can have healthcare providers who are actually experiencing, side effects from this. It's really important to make sure they're wiping off the previous dose before applying a new dose, right? And actually, this is really important that they're doing 12 hours on and 12 hours off, okay? So once they're done with the 12 hours, they need to remove all the paste that's still there, and then 12 hours later apply a new dose. And why do we do 12 hours on, 12 hours off?
How do we know padding in the eye?
No. So it wears off? Do you guys remember tachyphylaxis? We talked about this in pharmacodynamics. It was such a good word. We'll talk about it again in just a second, but just note that the 12 hours on, 12 hours off is really important. Okay, that's a key point with using nitro paste. Transdermal patches they have as well. Again, this is going to be another one that's 12 hours on, 12 hours off. Make sure they're taking off the old one and discarding of it. Certainly due to the vasodilatory effects, you expect to see headache, flushing, very similar to our dihydropyridines. This reflex tachycardia can occur here as well. So tachyphylaxis, which again is one of my favorite words to use in class. The mechanism is not fully understood, but this is that theory or that phenomenon that occurs that even if I were to keep increasing my dose of a drug, at some point I'm not going to see any further effect of it, right? So as opposed to something like tolerance to a drug where I can keep increasing my dose and still get some increased effect from it, like somebody used to do like an opioid or whatnot. With these drugs, once you kind of get to a certain breaking point, whether it be due to a depletion of cofactors, due to maybe counter-regulatory mechanisms like the renin-angiotensin system or your sympathetic nervous system, plasma volume expansion, things like that, eventually you're going to see that the nitroglycerin is just not going to be effective anymore. So if I were to keep this on 24 hours a day and don't really give the body a chance to replete those enzymes and those cofactors, it's just not going to be effective, right? So that's why we do 12 hours on, 12 hours off. We call it this nitrate-free interval, this kind of nitrate holiday, in order to prevent that from occurring. And you want to have the nitrate-free period being kind of where the patient has the lowest symptom frequency, which will typically be when? nighttime when they're not up and around, right? So some contraindications. So if they have aortic valve stenosis, because again, if you're decreasing that total, that peripheral resistance, it could be hard for the heart to really keep up with that. So it can be an issue of decreased perfusion, obstructive cardiomyopathy, and then also this concurrent use of phosphodiesterase inhibitors, particularly the PDE5 inhibitors. So sildenafil, tadalafil, and vardenafil. The reason for that is because you worry about this concurrent use that can lead to even further hypotension. And so again, if you are decreasing hypotension, or having hypotension to such a degree you're not perfusing well, you can actually end up inducing an MI or potentially even a stroke in some patients who are more predisposed to it. Really, the hypotension is really going to be the most common manifestation of this. So if you have a patient who has a history, say, of being on sildenafil and they're having acute anginal symptoms, you don't want to tell them to go ahead and use their nitrate unless they've used the sildenafil recently, right? And this becomes a big issue, especially with some of our long-acting agents, something like tadalafil ends up working for like 72 hours, right? So you can end up having a long period of time where you don't really want to use your nitrates for fear of dropping their blood pressure too low. Okay, this is an important counseling point here, especially for your older gentlemen. But certainly you can have patients who have pulmonary hypertension who might also be on this as well. So it's not uncommon for patients who have pulmonary hypertension to be on one of these agents because it also causes some vasodilatory effects in the lungs. So looking at how we should use these drugs, so we can see that based on comorbidity, you're going to have certain drugs you're going to kind of prefer. You have some alternatives and you have ones you want to avoid. So looking at hypertension, beta blockers are going to be a good option for this. An alternative might be a good non-dihydropyridine. Not really any drugs you should avoid specifically because these are all going to have good effects on decreasing blood pressure. If they had a previous MI, beta blockers are going to be best here. We'll see that this actually has mortality benefits for patients. We'll look at it in a little bit, and potentially avoid some calcium channel blockers, mainly due to the fact that this can actually potentially worsen ischemia, but mainly, especially if they have any like concurrent like CHF or something, you can decrease output, which can be problematic. Very similar to what we see with this left ventricular function here. You can potentially use amlodipine, but your non-dihydropyridines you would want to avoid in those patients. Previous bradycardia or AV block, probably use more dihydropyridines. They're not something that's going to be a direct cardiodepressant. Might be a good option there. Long-acting nitrate might be good here as well. But again, you want to avoid non-dihydropyridines in your beta blockers. For diabetes, non-dihydropyridines are probably going to be your first go-to drug. Really, the beta blockers are the big ones you want to avoid in that case, just because of the hyperglycemia and the masking of the hypoglycemia. And then asthma, certainly we can look at using cardioselective beta blockers. That's what that CSBB is. That might be a better option for those patients with asthma. Does that kind of make sense? So if you had a question on a test that came up and you said, okay, you got your 63-year-old male patient who comes in, he has hypertension, previous MI, and diabetes, which is going to be the best drug for him, right? So focus on those kind of disease states and say, okay, which might be best option for this patient? Maybe a cardioselective beta blocker or whatever it happens to be. I'll make it pretty clear cut though, based on his comorbid conditions, what will be the best option for that patient. Okay, so some other agents that are not strictly antianginals but can help to prevent further progression of disease to acute coronary syndromes. Your ACE inhibitors are going to be useful here, especially for patients who have diabetes and any degree of left ventricular systolic dysfunction. You guys remember why it's good for those patients? Well, one's kidney protective, so that's good for your diabetics. Really, it's this prevention of remodeling that can occur. So when this renin-angiotensin system is ramped up, you see left ventricular remodeling that can occur due to that kind of increased stretch and whatnot that occurs over time, and also just due to the issues on the kidney. ACE inhibitors are going to be really preferred for these patients. So they don't directly decrease myocardial oxygen consumption. They don't really relieve any symptoms of angina, but they may help to prevent further progression of disease, which is going to be good for our patients. You do see mortality benefits with these guys. So it should be used indefinitely for patients who have certainly history post-MI, any left ventricular dysfunction or diabetes. These patients should be on ACE inhibitors. And you can consider any patient who has coronary artery disease or other vascular disease, patients should probably be considered for it as well. So again, when should you use combo therapy? Typically you'll see that if angina is still persisting with monotherapy, or if symptoms maybe improved a little bit but not really to where you want them to be, you can combine potentially like a beta blocker and say like a dihydropyridine. You definitely do not want to do non-dihydropyridine with the beta blocker, and then you could also add on potentially a long-acting nitrate to either calcium channel blocker or a beta blocker as a third or as another agent. Again, if you need a third agent, probably need a better workup to see what's going on, because the guy's probably going to need more serious intervention than just these antianginals can provide. As far as antiplatelet therapy goes, really these patients should be on aspirin in the absence of any other contraindications. As far as platelet therapy goes, we're using it as a prevention of acute coronary syndromes. And really anyone with ischemic heart disease without contraindication should be on aspirin. We end up seeing that if you cannot tolerate aspirin for whatever reason, if you have contraindication, then something like an ADP receptor antagonist is going to be preferred as an alternative. So clopidogrel, prasugrel, ticagrelor, any of those drugs can be substituted in here. Which with clopidogrel is that's one I'm most familiar with. You do see that it's just as efficacious as aspirin in prevention of another coronary event. But again, it's going to be more expensive. Aspirin is just easier for patients to get a hold of and to take, so it's usually going to be your first option there. So again, so if you have a patient who has anginal symptoms, unless there's contraindication, they should be on aspirin. They should be on a beta blocker if they have previous MI. They should most definitely be on ACE inhibitor if they have diabetes or left ventricular dysfunction. They probably should be on some sort of lipid-lowering therapy. And we remember we talked about our hyperlipidemia guidelines saying that we're not really focusing on strict numbers of cholesterol. We're actually focusing on their actual risk for future coronary events. So again, most of these guys are going to be on kind of more high intensity kind of statin therapy in order to help kind of get that under control. And then they should have sublingual nitro for acute relief of pain, right? And then if they're having daily or more frequent symptoms, then that point is when you want to do the prophylactic antianginals, something like a beta blocker, a calcium channel blocker, and long-acting nitrate. Make sense for everyone? Yes.
Is this a pick, or they need to be on all of these?
So for that first group, they probably should be on all of those, unless they have like a contraindication, right? So this is why you can see that patients' med lists kind of become pretty unwieldy after a period of time, because now all of a sudden, if you have coronary heart disease and then you have diabetes, like you're going to be on at least like 5-6 medications, like no problem, right? And then you have the angina on top of that, and now you have nitroglycerin, potentially antianginals, so you try to kind of combine these where you can, so that hopefully, the patient was already on a beta blocker anyway for their previous MI. That's going to be good for their angina symptoms, right? So sometimes you're kind of getting double duty out of some of these drugs being used. Any other questions on that? Okay. If they are having that variant angina, that Prinz metal angina, big thing to focus on here is that calcium channel blockers and nitrates can both reduce your symptoms. You probably are going to end up going with like a dihydropyridine kind of as your first line to help prevent that spasming that can occur. But you do want to avoid beta blockers, because we said that the beta blockers, while they decrease oxygen demand, that's not really your patient's problem in this case. You want to increase that blood flow to the heart. Okay, we'll start off with the acute coronary syndrome before I give you guys a break. So we know that there's kind of two big classifications of acute coronary syndromes. We have our ST segment elevation MI, or STEMIs, and then you have your non-ST elevated acute coronary syndromes. That could either be unstable angina, which is that angina at rest, or non-ST elevation MI, or NSTEMI. We'll see that the treatment is going to be a little different based on what kind of medications you're going to be using specifically for these guys, based on whether they're having a STEMI or not. Okay. Certainly, we'll focus on looking. I'm sure you guys have seen stuff like this before, but we're kind of looking at the plaque, what's happening with it, and kind of where some of our medications are going to be targeted based on the pathophysiology of this. So certainly, say you have your coronary artery, you're going to have this plaque that's developing over time, especially if you're not controlling your diabetes and hypertension, all this other stuff. And you have this nice fibrous cap. That cap may not always survive. You may have issues where, if say you come along and do PCI and you come to a balloon deployment, and all of a sudden you can have maybe potential release of some of those kind of that injured endothelium is kind of more exposed now. Well, we know that injured endothelium can start to activate our clotting cascade. We can start to see platelet adhesion, activation, and aggregation that can occur here, right? So things like von Willebrand's factor and things like that are helping to kind of start to trigger these platelets to start to kind of grab onto that injured endothelium to try to clot it off. The other big thing, you're going to see these fibrin strands starting to form. So we're going to see specific drugs that are meant to kick off the degradation of that fibrin, because this fibrin is really just going to lead to further occlusion and to potentially full occlusion of that whole vessel there. And then you have this kind of occlusive thrombus that forms. So the big thing we're going to be focusing on when we're having these guys is that if we can we want to get rid of the blockage somehow. So it might either be a specific medication that helps to break down that fibrin, or it could be a potential more kind of mechanical intervention that we're doing to actually go and kind of open that vessel up. So one of the big things we're going to be seeing here is that thrombin is one of the major activators of this pathway. So certainly when that injured endothelium is exposed, you're going to have things like tissue factor kicking off your extrinsic pathway. We see things like collagen, which is going to be sending out things like ADP and thromboxanes. Remember, we talked about those when we talked about our anti-platelet agents. Both of these can lead to further activation of platelets through thrombin, platelet aggregation. We see thrombin also being really responsible for that kickoff from fibrinogen to fibrin, which is going to be the main component of that big clot that occurs after the platelets have kind of aggregated. So we'll see specifically drugs that are going to be, we'll use anticoagulants, things that can help to prevent the activities of thrombin. We'll also see drugs that are going to be working to directly kick off the degradation of fibrin. Remember, thrombin is factor 2, right? Perfect. So, if we're looking at anticoagulants, we probably want something that's going to be looking at affecting factor 2. What's another big factor where our anticoagulants are going to focus on? 10. Yeah, 2 and 10 are going to be the big ones. 10 and 2. I have a really big steering wheel. So look, again, just kind of going a little bit more detail on some of the factors that are involved here. So certainly when the endothelium is exposed, you have tissue factor and factor 7 kind of kicking off this pathway. You can see here where factor 10 starts to get involved, and you have a little bit of thrombin being made here, right? So 2 goes over to 2A, or thrombin. And then this, we talked about this being kind of a cascade, but it's also kind of a reciprocating kind of pathway to where thrombin can kind of start to initiate the release of further thrombin by kind of acting on other pathways. So we can see here thrombin can help to convert the activation of factor 11 there. We see that it helps to start to activate these platelets more, right? So we're going to have more platelet aggregation occurring due to thrombin influence. And then you have further propagation. And so also activation of these platelets is going to lead to further thrombin, and thrombin is really responsible for kicking off that fibrinogen conversion over to fibrin, okay? So we're going to be seeing that we're going to be using combinations of anticoagulants that help to prevent a lot of these factors from working, or they help to degrade those factors at a faster pace by working on things like antithrombin 3. And then we're also going to have drugs that are going to directly catabolize the fibrin itself due to activation of other enzymes. Okay, so when we're having a patient with an acute coronary syndrome, and we're going to focus on STEMI first, big things you want to focus on is 1, to reestablish coronary blood flow. That'd be a good thing. Relieve the chest pain. If they're not already having an MI, we want to help prevent progression to a full-on myocardial infarction. Prevent development of heart failure from developing. Again, that's going to be kind of an after effect of an MI or this ischemia. And then to prevent death. That's usually a good thing to do, right? Patients prefer it. So looking at the treatment of acute coronary syndrome, we see that there's going to be some common pharmacologic therapy, especially in the early stages when you don't know what you're dealing with yet. So especially patients who are having acute symptoms, you don't have a 12 lead on them to really determine what's going on with them. You're going to see the aspirin is going to be a first go-to drug, right? So typically we're going to be giving them either like 4 baby aspirin, the 81 milligrams, or give them a total of 325. They're going to take that and chew it and swallow. What does the chewing help to do? Not really the buccal absorption, but it helps just to kind of crush it up and helps to aid the absorption. You don't really need to worry about having the tablets disperse in the GI tract and then be absorbed. It's just already chewed up. It tastes kind of gross, but your patient's heart's dying. You probably want to help fix that first, right? So even if they're taking a daily 81 milligrams of aspirin, they'll probably still get in 325 of aspirin either by EMS or when they get to the ER or whatever happens to be. This has been shown to reduce mortality and to prevent reinfarction. All good things, right? Again, we're going to focus on things that help to decrease mortality or things that just work on symptoms. And it's important to keep in mind which one is which, because you don't want to give unnecessary medications unless you need to, right? Nitrates, no actual improvement in outcomes, even though they do provide some increased vasodilation to help increase O2 flow to the heart. But really, nitrates don't have any improvements on outcomes, right? And so we've seen that they do relieve chest pain. So if your patient's having chest pain, nitroglycerin might be a good option for them, right? If they're not having any pain, You don't necessarily need to do it. But this is probably what caused it in the first place. The chest pains would kind of alerted them to it, so you'll probably end up giving nitrates. And then beta blockers. Beta blockers are going to be really good because they do have a decreased risk of MI with patients who have unstable angina, and you're also going to see a decrease in mortality patients who do have an MI. So beta blockers are really good. You may not be able to start it off in the very beginning depending on what their blood pressure and heart rate's doing, but certainly if they have really bad hypertension, this might be a good agent to get on board as well due to the mortality benefits. We'll see when we talk about CHF specifically that only specific beta blocker should be given in that indication. Here you're going to be seeing that you'll start off with a lot of like IV type beta blocker. So metoprolol is a very common IV one. Labetalol is a common IV one. There's another one we didn't really talk about. We call it esmolol, ESMOLOL. That one's a very short-acting intravenous agent that can be utilized. And then eventually you'll switch over to PO for more chronic management. You do not want to give aspirin if they have obviously an allergy, if they have a recent GI bleed or recent intracranial hemorrhage because you were at bleeding risk. But again, the benefit mainly being here that you have decreased recurrent ischemia, infarction, stroke, cardiac death, all those good things. Looking at nitrates, so you want to start with sublingual therapy because that's probably what the patient has a prescription for at home. And then when they're in the hospital, if you need to, if they're having kind of continued chest pain, it's not really being relieved by the sublingual. If they're having really bad hypertension, you can potentially use an IV infusion of nitroglycerin to help kind of calm that down. Be really careful with your units. I've seen cases where a patient had a whole bottle of nitroglycerin infused into them over a few minutes because someone got the micrograms per kilo per minute versus micrograms per minute mixed up. So don't do that. That could be really bad. Because you worry about bottoming out their blood pressure, so you have severe hypertension, hypotension, a headache, reflex tachycardia. And again, if you're having a patient who's having an MI, you probably don't want to increase O2 demand by the heart by causing a reflex tachycardia, right? Not a good thing for them. So contraindications include they have any hypotension already there due to cardiac instability. If they've been on a phosphodiesterase inhibitor like your sildenafil, vardenafil, anything like that. And again, no mortality benefits, just going to be relief of chest pain. I mentioned the beta blockers start IV and then you can switch them over to PO, but if they have bradycardia, hypotension, heart block, this is the ones you want to avoid the beta blockers in immediately. They have severe airway, reactive airway disease. What might be a good IV one that I mentioned already to go to? Like really bad asthma. So you want to use beta 1 selective. Which ones are those? Remember A through M are your beta 1 selective.
Atenolol.
Oh, the E one.
So yeah, so actually esmolol is a cardiac selective one, so that would be a good one. Metoprolol is the other one I was kind of referring to as a common IV agent. So again, if they have reactive airway disease, you can use a cardioselective one that might be better for them. But like labetalol, that one has kind of mixed activities. That one might be one you want to avoid. So again, this will have reduction of early and late mortality, reduction in infarct size, heart failure incidence. So these are really good agents to have on board for patients as soon as they're kind of stable enough to receive them. Morphine, I thought this picture's hilarious. I don't know if you guys do. So morphine is, when you're thinking like an acute MI, like what are you thinking as far as like an acronym of medications to give? Has heard of MONA before? MONA, M-O-N-A. So MONA is an acronym that these are kind of the medications you're going to give to patients who are having an acute coronary event. So M stands for morphine, O stands for oxygen, which I'm not really going to talk about here. What do you think the N stands for? Nitroglycerin. And then the A? Aspirin, yeah, absolutely. So MONA, those are kind of the 4 medications or 4 interventions you want to start immediately. Morphine's kind of interesting because like unless your patient's really having significant chest pain, you don't necessarily need to give it, right? But it used to be one of those things that just everyone got right off the bat. If their nitro is dealing with their chest pain, you don't have to give morphine. It's not a big deal. They actually looked at they looked at these big studies and looked to see mortality and kind of what influence different things have on it. They actually saw that there might be a potential increase in mortality if you give it to patients having unstable angina or in STEMIs. Again, it's kind of controversial, but if your patient's still having continued chest pain despite receiving nitroglycerin, you can give morphine. Morphine is going to be an opioid analgesic. We'll talk more about those in the next class, but just be aware that it's mainly being used for chest pain. we are not using these for mortality benefits, though. So really no mortality benefits. Adverse reactions you can see with morphine specifically is that, one, they can have an allergy to it. So it means you need to find an opiate, a different opioid in order to give if they have an allergy to morphine. That also includes allergies to codeine as well, because codeine actually gets converted into morphine. So be aware of that kind of cross sensitivity. And then morphine itself leads to a lot of release of histamine, so you can actually see hypotension develop from giving, especially like big doses. So just be aware of that as well. So we've seen this slide before. We've looked at the clotting cascade. The main thing I'm going to focus on here, even though we will be using some anticoagulants that we've seen previously, I think like heparin and Lovenox, we'll mainly be focusing on the bottom part of the slide here for these new drugs we'll talk about. Mainly, these are the ones that are influencing that conversion of plasminogen over to plasmin. And plasmin is going to be the main thing responsible for degrading all of those fibrin into the fibrin products. Right? So that's the main thing is going to be our clot busters, and they're going to be actually going and lysing that clot open to reestablish blood flow. So another name for these are going to be our fibrinolytics, because obviously they're causing lysis of fibrin. So they're either going to be working to either directly or indirectly lead to the activation or the conversion of plasminogen over to plasmin. We see that normally plasminogen is inactive, flows through the bloodstream all the time, but you see activation of it with a natural product called tissue plasminogen activator. We'll actually see one drug which is a recombinant version of this, so you hear me refer to as TPA. And then plasma is also going to be useful for lysing not just fibrin, but also fibrinogen, and kind of the previous product, and then also factors 2, 5, and 7. There's also another product called streptokinase. This is one of the medications we'll talk about, but it actually forms a stable 1-to-1 complex with plasminogen and actually exposes a catalytic site, and that helps to kick off the conversion from plasminogen to plasma. So that's kind of a different way for the activation to occur, whereas tissue plasminogen activator is going to bound the plasminogen itself and causes the conversion to occur. So one kind of like indirectly leads to the activation of it by opening up that catalytic site. The other one goes and directly activates it itself. So you can imagine this picture here. So you see things like streptokinase or plasminogen will kind of open up that activator complex versus something like urokinase or TPA will do directly cause that conversion to occur. So we see that streptokinase and urokinase are two agents you might see used. They're going to activate both circulating and fibrin-bound plasminogen, whereas something like tissue plasminogen activator or retiplase and also tenecteplase, which is going to be another agent, only activate the bound fibrin plasminogen. So if you had to imagine which one's more specific, you imagine one that's going to be just affecting the bound fibrin. It's going to be a little bit better. So typically what you're going to see used in actual clinical practice is more use of things like TPA, this retiplase, and also tenecteplase. Those are probably the more common ones you're going to be seeing being used. You'll see between all of them you're going to have very similar responses and adverse effects. And if you can imagine, what do you think is the most significant adverse effect we're going to be seeing with these agents? Bleeding, absolutely, right? So it's kind of they're very dangerous drugs. You want to make sure you're using these in the right patients, because otherwise you can cause some very significant bleeding, not just in the area where you're trying to treat it, but also in other areas as well. So it's not uncommon to hear of hemorrhagic strokes and things like that developing after administration of these drugs. Now, we don't only use these for acute coronary syndromes. Can you guys think of any other places where we want to lyse a big clot? Yeah, stroke would be another big one. Ischemic stroke, anything else?
Pulmonary embolism. Like
a massive pulmonary embolism, like that might be another case you might use it. Myself, I've seen some interesting cases of TPA being used specifically. We have an interventional radiologist that works at Nemours, and so he does a lot of like very kind of direct guided kind of applications of TPA. So we've had cases where patients will come in with either like an empyema or I'm trying to think of the other situation, but basically we give TPA through a chest tube to actually help kind of loosen up that stuff. We've had this is also TPA is another one you actually use if you have a catheter that has a clot in it. You give a smaller dose that you actually would instill directly into the line that will actually help break up any clots that are in the line itself. So for catheter patency, you'll see these drugs being used as well, TPA specifically. So again, bleeding is going to be our major adverse effect. We're also going to worry about allergic reactions. So a lot of these are going to be kind of more protein-based products. So they can lead to kind of more minor allergic reactions like fever, chills, rash. You see those more things like streptokinase and urokinase, but certainly you run the risk of anaphylactic reactions. It's a little bit less with some of the newer agents we're going to be seeing used. So I haven't really ever seen an allergic reaction to TPA before, but certainly it's possible. And then you also worry about risk for things like ventricular arrhythmias. But of course, if your patient's having an MI, what are they already at risk for? Ventricular arrhythmias, right? So who's to say if it's the chicken or the egg in that situation? So this is really important to know for deciding if your patient is going to be a candidate for receiving one of these drugs, right? So if they fall into any of these contraindications, don't give it, right? So these are going to be absolute contraindications. So you might have a question on the exam that says if you have this type of patient who's got X, Y, and Z, is he a candidate for TPA? Might be a good thing to know. So if they've had recent history of surgery within 10 days, including any kind of organ biopsy or anything like that, they're going to be at a bigger risk for bleeding, right? So you don't want to do it then. Any kind of like serious trauma, if they've had CPR recently, you don't want to give it. Significant gastrointestinal bleeding within 3 months, history of hypertension. That's kind of more of a relative one. You'll typically see that if they have a certain threshold, so usually if they have a diastolic pressure greater than 110, that would be an absolute contraindication. Or if they have, say, like I think usually systolic's like around 180 or something like that, where you would not want to give it. You can give them an antihypertensive, and if that resolves, then you can give the drug. So usually patients will end up getting like 2 tries or 2 rounds of an antihypertensive, and if it still doesn't resolve, then you just wouldn't give the agent. So I normally would see that, and honestly, I normally see more of these fibrinolytics being used in the case of like ischemic stroke than I do in MI, because really what's kind of the primary intervention for someone with an MI? Yeah, usually get a cath, right? Usually you go with some kind of percutaneous coronary intervention versus giving one of these systemic fibrinolytics. So you will see these used probably more frequently in things like ischemic stroke, and so a lot of times those patients are very hypertensive, and so that usually is common where you give them an antihypertensive, still hypertensive after that, you give another dose, and if it's still nothing, then you just don't give the drug. Obviously, if they're having acute active or hemorrhagic disorder, previous cerebrovascular accident, or if they have some kind of tumor, some kind of active intracranial process, dissection, acute pericarditis. If they've had, so this is kind of interesting one, specifically to streptokinase, otherwise abbreviated as STK. If they've had a previous exposure, because that actually patients can be sensitized to that and have an allergic reaction the second time they get it, that would be a contraindication, and if they're pregnant.
So they only get one try at this drug. You can't ever give it again.
For streptokinase specifically, so we'll talk about that, but really you don't see this being used clinically in the U.S., so more so in Europe. This one's actually developed from beta hemolytic strep, and so it's kind of interesting because if patients already have strep antibodies, then potentially they could have a reaction to this right off the bat without ever having received it before. But again, this is working more specifically by not directly causing the activation, but more as an indirect method by causing that catalytic site to become more visible, to be acted on by things like normally circulating TPA. Again, you'll see it used with other anticoagulants. You may see it being used with aspirin in the case of an acute coronary syndrome, but you do run a risk of rethrombosis for some of these patients. So this one not really used a whole lot in the U.S., but I just mentioned it for completeness sake. Urokinase is another one not frequently used in the U.S. We do see that this is actually developed from human fetal kidney tissue. So actually you can take that tissue and have it actually produce urokinase. You notice a lot of these agents are going to be things that our body's naturally producing that we're just getting kind of more either recombinant forms of, or we're developing it from some other tissue. This one you don't see it being so antigenic, but you can use it for things like pulmonary embolism and occluded catheters. These are the other 3 you're more likely to see in the U.S. I see a lot of TPA. Specifically, you're going to see this most commonly used as catheter occlusions. So Activase would be one of the names, the brand name for that. The Retiplase and then also Tenecteplase. Notice our Chinese hamster ovary cells are making a repeat. No salmon sperm in this lecture, but I don't know what it is about Chinese hamsters. They're so much better at producing these things than like American hamsters or German hamsters, but for whatever reason, they're very good at it. Yeah. Anywho, these drugs are very expensive because, again, these are kind of recombinantly made products, so they're very expensive, so it's not something you want to waste necessarily. And just keep that in mind. Not a whole lot of difference. You may see some difference in like indications that these are actually being marketed for based on the package inserts, but they can kind of be used somewhat interchangeably to some degree. But like I said, TPA, Alteplase is probably the most common one I see being used. I see it a lot for ischemic strokes. I see it a lot for massive PEs, things like that being used. Again, with our indications for using a fibrinolytic, typically you're going to have patients, the younger they are, the less likely they are to bleed. So if they're less than 75 years and they're within 12 hours of symptom onset, they might be a candidate for this. If they're greater than 75 years and they're greater than 6 hours past the onset, or if they're having a non-ST elevation MI, then you would not want to use these drugs, right? We know there's less benefit that if they're longer or they're farther out, and then in STEMIs you're typically not using these. But again, if you think about, usually you want to send them to a cath lab, right? That's usually the biggest thing in time is tissue. So the faster you get them to the cath lab, the better. You may be in a place where you don't have access to that, right? So if you're in a place where you're out in the Panhandle and there's the nearest cath lab is several hours away, that might not be a good option. So this is where you're going to see more of the fibrinolytics being used in the place of a cath lab. Bleeding, like I said, is the biggest thing. So anywhere between 0.5% to 7% may have some kind of bleeding. Intracranial hemorrhage can be up to 1% of patients. It's kind of even I don't like those odds. 1 in 100 patients are going to have an intracranial bleed that they didn't come in with. It's going to be pretty significant. So this is why cath lab is so much more preferred, because you can do much more kind of guided, direct interventions as opposed to giving a systemic drug, which can cause bleeding anywhere, right? So some other agents we'll see being used, so specifically for ST elevation MIs, we don't typically see those 2B3A receptor antagonists really being used. Do you guys remember any of those drugs? Boy, it just dumped everything after the last test, huh? So do you guys remember any of those 2B3A receptor antagonists? It's like abciximab, tirofiban, eptifibatide. So you don't see those used a lot for ST elevation MIs. You see those more being utilized in non-ST elevation MIs or unstable angina. We'll talk about that in a second. You may see some of our ADP receptor antagonists, things like your clopidogrel, potentially being used prior to PCI as kind of clot prophylaxis, especially if they've had a stent placed. So whether it be a bare metal stent or a drug-eluting stent, you'll see clopidogrel typically being used, or clopidogrel, prasugrel, any of those other agents in order to help prevent clots on that. And then you'll see a lot of these patients being started on heparin as well. So again, you'll have a patient come into the ER, they'll be started on a heparin drip or potentially Lovenox in some cases, like enoxaparin, and you'll see that used in conjunction with the fibrinolytic or antiplatelet agents, right? So you can see heparin used on a lot of these patients. Again, here's just an example of what that PCI might look like. And then for non-ST elevation MIs, this includes unstable angina, or I guess non-ST elevation acute cardiac syndrome includes unstable angina and MI. You're going to see that the initial treatment's pretty similar, but really the fibrinolytic risk is much greater than any potential benefit you may get from that because the occlusion just isn't as great. So you're not going to really use this very frequently. Typically more, cath lab is going to be your best option there. And then you may use enoxaparin more frequently than heparin as an anticoagulant. And then you'll also see the 2B3A receptor antagonists being used more frequently prior to them going to the cath lab. Any questions on acute coronary syndromes? So remember, we started off, what are your first couple drugs you want to give? Mona, right? So Mona's a good one. So what's Mona stand for? Morphine, which do you always want to give that? No, only if they're having continued pain, not relieved by? Nitro, right? Okay. Then you want to give them?
Oxygen.
Yep. Should you always give them oxygen? Yes, always give them oxygen. And then? Well, nitro and then your aspirin. Yep. Perfect. Okay, so moving on. So say you've had an MI, you've had some of this left ventricular remodeling, and now you have an impaired cardiac output, bad ejection fraction. Now you have CHF. So how are we going to treat that? So we know that we see about 50 to 60% of cases, the etiology comes about from ischemic heart disease and MI. So it's a very frequent type of patient you'll see with that. Certainly other things can exacerbate this, hypertension. You may have some idiopathic cardiomyopathies. Certainly alcoholism, you have a viral cardiomyopathy, lots of different reasons for it. There's also some drug-induced cardiomyopathies that can occur. There's an interesting case where, from a toxicology standpoint, has anyone heard of Ipecac? You see the Family Guy episode? They drink Ipecac. So it was a common drug they used to recommend for inducing vomiting in patients who had ingested a poison, a long, long time ago. And so some people, young young adolescents would actually abuse this as kind of a bulimic agent, and so you'd have these like very young, thin girls coming in, and they have these like ginormous hearts because actually one of the components in ipecac was a cardiotoxin. So that was one example. There's some chemo drugs that can potentially cause cardiomyopathies we'll look at, and they can lead to CHF, and actually have like kind of lifetime max doses, as we'll talk about in a couple weeks. But lots of different causes for CHF that can occur, but most of them are going to come about from MI and ischemic heart disease. You can have systolic dysfunction. So this is typically related to decreased contractility. So some of the causes for this, if you had loss of myocardial muscle mass, if you had left ventricular hypertrophy, so the muscle just gets nice and thick and not very compliant, and then also with dilated cardiomyopathies where things are just kind of really stretched out. Typically, you're going to see these guys are going to have a reduced ejection fraction, so say less than 45%. As opposed to your diastolic function, this is more related to impaired relaxation. And so with that left ventricular hypertrophy, again, this is a bigger issue of having decreased compliance there, so it just can't relax and fill appropriately. You can also see issues with ischemia and calcium being not recycled appropriately. So you'll have decreased ventricular filling, and that'll lead to a decreased cardiac output from situation. So these would be patients who have still an okay ejection fraction. They just don't have a very good cardiac output just due to the fact that the left ventricle can't fill very well. And so those would be patients who have heart failure with preserved LV function. Okay, you'll see treatment is not really going to change very much based on that, though. So your compensatory response, so if your body's sensing that your heart's not sending out enough blood, it's going to do things like increasing preload. So it's going to work by, especially through our renin-angiotensin system, to increase sodium and water retention. It's going to cause vasoconstriction, which again, we'll see in a second how this is kind of a self-perpetuating kind of disease state where the compensatory mechanisms are actually worsening the disease state and so on and so forth. And then also by just having the left ventricle get more muscle mass and hypertrophy, that's going to try to compensate for that as well. So again, you can imagine here, have someone with heart failure has a decreased cardiac output. They're decreasing their tissue perfusion. It's going to lead to lots of different compensatory mechanisms. So renin-angiotensin system, we've talked about all this pretty extensively, but all that's going to really kind of lead back to worsened cardiac output in the long run. So we want to do anything we can to help kind of prevent or kind of break that cycle from occurring. Because again, can we fix the heart failure itself? Not really. Let's give them a transplant, right? Like you can't really fix a lot of that remodeling, but what we can do is help prevent further remodeling from occurring. We can help prevent progression of disease as best we can. So certainly you guys probably have heard the signs and symptoms of heart failure before. I won't really get too much into that, but notice here that you can see things like peripheral edema, distension of the jugular vein, things like that. So you're having fluid overload is really one of the big things we're going to be focusing on here. A lot of the medications that we're going to be using can be used to help decrease a lot of that fluid overload that we're seeing as a compensatory response to that decreased cardiac output. You also can have patients have acute decompensations where they have basically, they're trucking along just fine, and all of a sudden they have a decompensation where it can be due to a lot of different things. So certainly a lack of compliance with either their lifestyle modifications or medications can lead to this. Uncontrolled hypertension or arrhythmias can do this as well. Or if they're just not really being managed appropriately. So say they have inappropriate medications on board or they have fluid overload, all this can lead to a decompensation, right? So we also want to focus on medications to help prevent that in the first place. Looking at non-pharmacologic therapy, certainly by limiting our sodium intake, that can help to decrease a lot of that fluid overload that we're having there, and also decrease just the amount of fluids they're intaking in the first place. You may also see that they have a degree of exercise intolerance based on how kind of far along they are in the disease process, but actually having some physical activity can kind of help them in the long run, help improve their functional status. But we want to talk about drugs because this is pharm, right? So the first class of drugs we'll talk about, and this is another one where it's important to recognize which drugs have benefits on mortality and which ones don't, right? Because if they're not having some of these symptoms and there's no benefit on mortality, no point in giving the drug. So looking at thiazide diuretics, although these are good for hypertension, they're not really potent enough to work for most of your heart failure patients in order to get rid of that fluid overload. So loop diuretics are going to be your mainstay of therapy for fluid management. Right, not for hypertension management. This is more for your fluid management. So by decreasing the amount of sodium and water reabsorption occurring in the kidneys, and where does it work in the kidneys? the ascending loop of Henle, you're going to increase the amount of fluid that's being released via the urine. So one of the good ways to monitor for this is to check their weight daily. So by looking at their weight, if they start to go up a couple of pounds over the course of a few days, that's pretty indicative of fluid overload. So either their dose of their diuretic's not good enough, or something else is going on. Maybe they're decompensating currently. So is there any reason you'd ever want to use a loop and a thiazide at the same time?
Calcium.
For potassium?
Calcium.
Oh, calcium, maybe for calcium, to help prevent hypocalcemia. Any other reason? So I don't know if I talked about previously, but I ever mentioned loop resistance? All right, so this is a phenomenon that occurs. So your kidneys want to maintain, your body's always trying to maintain homeostasis. So there's always a compensatory mechanism for usually any medication we're giving. So your loop diuretics are working at the ascending loop of Henle to decrease the amount of sodium reabsorption. Well, what does the distal convoluted tubule do as well? Well, it helps get rid of water, but also reabsorbs sodium, right? So your body can compensate for that by increasing the amount of sodium and water being reabsorbed at the distal convoluted tubule. And so after a while, your body's going to compensate to those loop diuretics and have this degree of loop resistance that can occur. So one thing that you can do is give a low-dose thiazide in addition to the loop diuretic and actually overcome that. So that would be one of the indications where you might see, if you're giving a loop over a long period of time and they're developing this resistance, just not working like it should, adding on a low-dose thiazide actually can kind of help fix that, right? So that may be a case where you might see those two medications at the same time. But keep in mind, this is for symptomatic relief only. So these are really only dealing with the fluid overload. Diuretics are not going to do anything to decrease progression of disease or change mortality, right? So it's not mandatory therapy, but if they're having symptoms of fluid overload, yes, go ahead and use it. Now, looking at ACE inhibitors, this will have a very good effects on your mortality. So these are going to work to decrease preload, they decrease afterload, they help to decrease our sympathetic activation, they decrease a lot of those compensatory mechanisms we talked about that help to worsen heart failure in the first place. They can help to prevent a lot of that remodeling, like the left ventricular hypertrophy, the dilation, all of that. So hopefully we can slow any heart failure progression and hopefully decrease mortality in the long run while they're taking these. So, like I said, we see hemodynamic improvements, you see better exercise tolerance, decreased symptoms. You also will end up seeing decreased hospital admissions, slow progression of disease, and prolonged survival. Could I give an ARB instead of an ACE inhibitor? Yeah. Absolutely, so it could be interchangeable, right? So if you have a patient with a really bad cough, lisinopryl's not working for them, switch them over to something like losartan, right? Some of the problems we can see. So do you remember who's really at risk for having impairment of renal function? What type of diabetics? Because it says it's good for diabetics, right? Because we said it's kidney protective. So patients who already have really significant kidney insufficiency that are really relying on that Ang2 to help cause that vasoconstriction on that efferent arteriole, if I give that to those patients and I relieve that vasoconstriction, I can see an acute decrease in renal function, right? So for those patients, you do still want to have an ACE inhibitor on board, but you start at low dose and kind of didn't really titrate up, right? So be aware of that. So it's not an absolute contraindication, but just be aware. You can see hypotension. You also will worry about elevation of serum potassium. So if they have concurrent kidney issues, you also want to worry about that as well. And then the cough and the angioedema at risk. So certainly this could be a good thing where if I'm giving a loop diuretic, like what's a good example of a loop diuretic? No. Yeah, Lasix or furosemide. Any other ones? Yeah, Bumax or bumetanide, torsemide, those are all good loop diuretics. So I'm giving that, that's doing what to my potassium? Should be lowering it, right? Because I'm decreasing the reabsorption of potassium. So by giving an ACE inhibitor, you can kind of help balance that out a little bit, right? So you can kind of help, they may not need to take potassium supplements because they have an ACE inhibitor on board. So again, you can see kind of some interplay between these different drugs. Looking at beta blockers, so these, a long time ago used to be considered contraindicated because, like, I have a patient who has poor cardiac output. Why would I want to put them on a beta blocker? It's just going to worsen that, right? Because I would never give a non-dihydropyridine to these patients. Let's add some other really compelling indication. But what they actually found was by giving certain beta blockers, these are the ones that have been studied and actually have mortality benefit associated with them. So it's not just any beta blocker. These are really the big three. I think there's a fourth one now, but it's a kind of a newer drug that I haven't really been too familiar with. But these are the three main ones you'll see being used. So the three are going to be carvedilol, which we've seen before, metoprolol succinate, which is the extended release preparation. So if you ever see metoprolol tartrate, that's going to be the short-acting form. Okay, so I think sucks. I think sucking on a hard candy that lasts a long time. So that's how I kind of remember which one's the long-acting form of metoprolol. So Toprol XL, and then also this bisoprolol or Zbeta are going to be your go-to heart failure beta blockers. And again, you worry about causing an acute decompensation, so you can't give them full strength dose right off the bat, right? Because otherwise you're going to have an acute decompensation. They're going to be in the hospital. So ideally, what you'd want to do is to, if they could be monitored, so say they were already in for for an acute decompensation and they weren't on a beta blocker previously, that's a good opportunity to start them. But you do very low doses and you titrate over like 6 to 8 weeks to get to kind of where they can tolerate it as best. So you kind of titrate up to the highest dose you can, to what the guidelines recommend up to a point, and then if they can't tolerate it at a certain point, then you just stay at that dose. So again, monitoring wise, though, you're just looking for worsening heart failure symptoms associated with that. So again, benefits of this, we're going to see improved exercise tolerance. We see better hemodynamic improvements. So actually you can see an increase in their ejection fraction even though they're on a beta blocker. And the way it's kind of described to me, especially if you have kind of impaired filling, by giving a beta blocker, you kind of slow down the heart enough to allow the ventricle to kind of better fill. It gives it a little bit more time to do so. So kind of think about it like that. And then in the studies, we've seen slowed disease progression. So you have less hospitalizations, less need for transplant, and also decreased mortality. So these are definitely ones you want your patients on as well. So again, these are going to be first-line therapy for class 2 through 4 heart failure, and then they should definitely be on an ACE inhibitor and a beta blocker, irrespective of the symptoms they're having. Okay, a new drug we've kind of probably alluded to previously is going to be digoxin. This is actually kind of has a steroid nucleus to it. It's a natural kind of product. Does anyone know any kind of plants that you can get digoxin-like compounds from?
Foxglove.
Yeah, foxglove. What's a common one that grows here in Florida? It's like on all the highways. Oleander is the other big one. So you can actually have oleander if a pet or animal gets into it, and it can actually have digoxin toxicity. So anywho, so essentially you have this natural compound, it's been around for a good long time, and CHF is one of the main places you're going to see it being utilized. The way this works is it works to inhibit the sodium-potassium ATPase pump on the myocardial cells, right? So by inhibiting that pump, what's that going to do to intracellular sodium concentrations? Should go up, right? Because that sodium-potassium ATPase pump is kicking sodium against the concentration gradient. So if I inhibit that, I'm going to have higher intracellular sodium concentrations, okay? What that's going to do is by increasing that, it's going to cause that other transporter, that sodium calcium antiporter, it's going to have that increase its activity, and so I end up having increased intracellular calcium. So what do you think having increased intracellular calcium in the myocyte does? Yeah, it increases contractility. So that's kind of the old way of thinking of why we use digoxin for CHF. It's by increasing contractility, you can increase your cardiac output and your ejection fraction. So again, that's an older mechanism of why we used it. We actually shot for higher levels. If you guys remember back to pharmacodynamics, digoxin is an agent we actually do therapeutic drug monitoring on. So we will see specific levels we'll actually be shooting for. The newer mechanism is more to do with neurohormonal effects. It's thought to lead to decreased sympathetic activation and increased parasympathetic activation. You can also do some other things like resensitizing the baroreflexes in the kidneys that deal with pressure regulation, and also decrease the renin-angiotensin-aldosterone system. So these are all kind of more holistic effects you can see from digoxin, and we can actually end up shooting for lower levels with this as well. So again, just some activity here. So again, by affecting that sodium-potassium ATPase pump, this is where we can see some of the decreases in sympathetic activity and all that. So again, looking at the target levels here, note that a lot of things are measured in either milligram per deciliter or micrograms per ml. Notice this one is nanograms per ml, so just be aware if you ever see these units, that's appropriate for that. And here you're actually shooting between a level of 0.5 and 1. When they end up seeing higher concentrations, you always worry about actually worsened outcomes in patients with heart failure. So this is really the ones you want to shoot for. So some of the benefits you might see, you'll see definitely improvement in symptoms. You can see improvement in exercise tolerance and quality of life. Decreased number of hospitalizations, but no actual survival benefit. So this is one of those other things that, if your patient is still symptomatic, they're kind of in tip-top shape on their beta blockers, ACE inhibitors, and say diuretics, they're still having symptoms, digoxin might be a good option to add on at that point. Which I mentioned here. You can also see digoxin potentially being used for AFib, and so you can potentially have a role for it here if you had a patient at AFib and history of heart failure as well. So the toxicities are really particular here. So this is the reason why digoxin doesn't get a ton of use, because it's pretty toxic medication if not kept in the right ranges. Big things you're going to be seeing here include a lot of visual disturbances. Anyone know what xanthopsia means? Yeah, it's a yellowing of the vision you can actually have happen here. They talk about seeing halos, yellowing vision. Those are big ones you see. And then also anorexia and nausea. So certainly with more chronic patients who are on digoxin, you're more likely to see the visual disturbances. So that should be a good education point to say, hey, if you see this, you probably need to come in and get checked out, because digoxin is renally eliminated. And if your renal function goes down, all of a sudden you're building up digoxin levels, you can definitely see this. Again, you can see some other CNS symptoms pop up here, like delirium, fatigue, confusion. And then also the other big thing you worry about is a cardiac effect. So digoxin itself can be a cardiac depressant. You can end up seeing nodal slowing, so you can see increases in your PR interval. Bradycardia can happen here, and then you can also see these after depolarization. So digoxin is kind of interesting because you can even see bradyarrhythmias and tachyarrhythmias. It just depends on your patient how kind of susceptible they are to that. So contraindications to receiving digoxin. So if they have a history of advanced AV block or severe bradycardia, you'd want to avoid in those patients. Any history of PVCs or VTAC, it can be worsened by dig. Hyperkalemia is another big one as well. So if your patient has poor renal function, they're already experiencing hyperkalemia, you don't want to give digoxin because that predisposes them to having arrhythmias. Hypercalcemia, hypomagnesemia, really want to make sure your electrolytes are in the right order prior to giving dig. And then Wolff Parkinson White would be another contraindication. So what happens if you have too much dig on board? You know, and your patient has poor renal function, you can't really get rid of it very effectively. They actually have an antidote for that, so I'll just mention this one briefly. This is the digoxin immune fab, otherwise known as Digiband or Digibind. This is actually an antibody. This is just the FAB portion of the antibody, so actually cleave it, so it's not as immunogenic. But essentially what they do is they will actually immunize sheep with digoxin. And then once they have those antibodies, they can spin those out, grab them, and then cleave them, just so we have the FAB portion. And that allows you to administer it to a person and actually bind up the digoxin to be eliminated in the kidneys. So you have really, really rapid reversal of toxicity. Even if they're having very severe arrhythmias, you'll see them clear up in a matter of minutes after giving it. So it's a pretty cool drug. Some other drugs we'll see potentially being used for CHF include our aldosterone antagonists. So remember, these are not just potassium-sparing diuretics, but the aldosterone antagonists specifically, because we know in CHF our renin-angiotensin system is going to be upregulated, so we want to inhibit aldosterone if we can. So spironolactone does have mortality benefit if you give it in more late-stage heart failure. So say stage 3 or 4, that's where you're going to see mortality benefit. But it's important to remember who's not eligible for spironolactone. So patients who have a potassium greater than 5 or serum creatinine greater than 2.5, you don't want to give that. Because again, what is this going to do to your potassium levels? Should increase it, right? And it's also, having poor kidney function can also lead to further increase in potassium levels as well. Again, we talked about side effects previously, but gynecomastia can be one definitely seen in men, especially at higher doses. And so a pleuronone might be a better option. You don't really see any gynecomastia with that drug. So again, that could be an alternative drug there. The idea here is by inhibiting aldosterone specifically, you may actually see slowed remodeling of the left ventricle, which would be good for mortality benefits in the long term by slowing that progression of disease. All right, some other inotropic agents you might see being used. So, if our cardiac output's poor, our ejection fraction is poor, we can actually give drugs that will directly stimulate the heart in order to kind of increase that. So these would be drugs you might see being used on the inpatient side for an acute decompensation. So these would not be like long-term kind of chronic management of heart failure. So two big ones you'll see here include milrinone and anambrinone. These are actually phosphodiesterase 3 inhibitors. So when we talked about our erectile dysfunction drugs, those are actually PDE5 inhibitors. So you normally see PDE5 mainly working in the genitalia and also in the lungs. We see PDE3 more working in the cardiovascular system. So by affecting phosphodiesterase 3, you can end up seeing some vasodilation, but you can also end up seeing increases in cyclic AMP within the myocytes, which can stimulate contractility. So these are both inotropic and they have vasodilatory action. So usually, your heart failure patients are going to have hypertension, so it's going to be useful for that. They're going to directly stimulate the myocardial contraction. And then they'll, by the vasodilatory effects, you're going to have decreased afterload and increased cardiac output. So these are good for acute decompensations. Typically, they're given as continuous IV infusions. They have a pretty short half-life. And they really aren't recommended unless you're having that acute decompensation, because there's not really a lot of mortality benefits seen with using it. But you do run the risk of having hypotension, arrhythmias are possible here, so I really don't want to use these agents unless you really have a compelling use for it. And then some other agents. So we have dobutamine. This is a specific beta-1 agonist. So this is kind of a unique drug that directly affects the beta-1 receptors. This is again going to be by stimulating that, you're kind of reproducing the effects of the sympathetic nervous system to increase contractility and heart rate. So those are good for short-term use to help stabilize your patients. And then you may also see a drug called dopamine being used. You guys heard of dopamine before? Yeah, so it's a common vasoconstrictor that actually works not only on dopamine receptors, but can also work on some of the adrenergic receptors at higher doses. So it can work on beta-1 receptors to increase cardiac output. But it's also got some vasodilatory actions in the kidney, which can be useful. So again, all those will be given by kind of short-term, continuous infusions, IV, until you get the patient stabilized, and then you can get them kind of tuned up on their other medications. Okay, so any questions on this material? Yes?
You meant digoxin is toxic. Is that something you do drug monitoring for?
Yeah, so absolutely. Digoxin is a therapeutic drug monitored drug, so you'd be doing levels on it to make sure they're staying within that 0.5 to 1 range. Absolutely, yes.
When you say acute decompensation, what do you mean by that?
So acute decompensation. So say they are, on a normal day, they're tuned up on all their medications. They're not really having a big degree of exercise intolerance. They're not having a lot of fluid overload. Anything can come along and happen. They can get they can get sick. They can a viral illness or anything like that. Say they have non-compliance with their medications, anything like that. So you're going to end up seeing increased symptoms of their heart failure, right? So decreased exercise tolerance, you're going to have increased fluid overload. They're just really going to be looking pretty bad, right? So then when they have that decompensation, you bring them in. You probably are going to give them IV diuretics to help get the extra fluid off, and then because their cardiac output's so poor, you're probably going to put them on either one of those, milrinones, or you may put them on dobutamine or dopamine or something to help increase that cardiac output, right? So it's really just that acute decompensation and the ability to maintain their cardiovascular status. It's a good question though. Anything else? Someone reminded me I did not put up the test average. It was certainly better than the first test, but I'll put that up today. I think there's only one high miss question, so I'll go ahead and put a explanation on that one. Any questions from the test you guys had? Anything came up? No? All right. You guys stay dry. Hopefully don't have too much hurricane damage, and I'll see you next time.